Good morning, everyone. I'm Dr. Nikita. My title is Intra Complication and Visual Outcome in Patients with Pseudoexfoliation Undergoing Manual Small Incision Cataract Surgery. Introduction. Pseudoexfoliation syndrome is a multifactorial diffuse disease having both systemic and ocular manifestation. It is characterized by deposition of elastotic material in different tissues and is diagnosed clinically on slit lamp examination of the eye by deposition of white dandruff-like material on different structures in anterior segment, namely corneal endothelium, iris, pupillary margin, anterior lens capsule, zonules, and trabecular meshwork. Systemically, the pseudoexfoliation material deposition is seen in different parts of human body, example lungs, heart, liver, kidney, blood vessels, and meninges. Thus, the patients with pseudoexfoliation may have hypertension, cardiovascular diseases, stroke, or abdominal aorta aneurysms. Ocular deposition of exfoliative material is seen on pupillary margin, iris near the ciliary process and anterior lens capsule, and it causes iridopathy, poor pupillary dilatation, and zonulopathy, zonular weakness, leading to high risk of intraoperative and postoperative complication. Scorelli and others has found that cataract surgery in pseudoexfoliation eyes has 5 times greater risk of intraoperative complication compared to normal eyes. Thus, in our study, we aim to evaluate the intraoperative complication and the visual outcome in pseudoexfoliation patients undergoing the cataract surgery. Material and methods. The study included patients attending Regional Eye Hospital Kurnool OPD from January 2023 to June 2023 with cataract and pseudoexfoliation. Demographic factors like age, sex were noted. The visual acuity was assessed with Snellen's chart. Complete ocular slit lamp examination was done to specifically look for pseudoexfoliative material after dilatation of pupil. Signs of zonular instability such as lens subluxation, zonular dialysis, iridodonesis, and phacodonesis were noted. The pupil size of less than 5 mm after dilatation was considered to be poor pupillary dilatation. All the patients underwent manual small incision cataract surgery. The surgical difficulties and complications encountered during the surgery and postoperatively were noted. Postoperative visual acuity was assessed on post-op day 2 with Snellen's chart. In results, manual small incision cataract surgery was performed in 40 eyes with varying grades of cataract and pseudoexfoliation. The age group of patients was 45 to 75 years, including 22 females and 18 males. Pseudoexfoliative material on pupillary margin was noted in 38 patients out of 40, which was the most common finding noted. Majority of patients had advanced cataract and inadequate mydriasis in 80% of patients. Posterior capsular rent was seen in 5% of patients and zonular dehiscence in 10%, with were the intraoperative difficulties faced. Uncorrected visual outcome on second postoperative day was moderate to good in 85% of patients, limited by postoperative corneal edema in 20%, iritis in 10%, and raised IOP. Surgical complications faced. Zonular dialysis was seen in 8 patients out of 40. Posterior capsular rupture was seen in 4, and vitreous loss was noted in 2 patients. Postoperative complication followed as corneal edema with SK in 20% of patients, raised IOP in 10%, AC reaction was seen in 10%, exudative membrane was seen in 2 patients, 5%. These are some pictures showing pseudoexfoliative material at the pupillary border. This is post-op picture of iritis, exudative membrane in pupillary area, and AC reaction. Discussion. Patients with pseudoexfoliation have a high prevalence of rigid pupil with poor dilatation. Pupillary dilatation of less than 6 mm is reported to be as high as 94.1%. In eyes with poorly dilating pupil, intraoperative bimanual stretching was performed with iris repositor, iris hook, and along with use of cohesive viscoelastic. Intraoperatively, it is a challenging task to make adequate capsular axis of 5 to 5.5 mm in diameter due to coexisting poor pupillary dilatation, thin fragile capsule, and zonular weakness. Sometimes there is also a presence of false capsule due to deposits of exfoliative material. We were able to achieve a complete rhexis in 80% of patients, and 20% we face difficulty. Presence of severe zonular weakness can lead to dreaded complications like lens subluxation and vitreous loss. Postoperatively, there is high incidence of capsular phimosis, postoperative iritis, and corneal edema associated with excessive intraoperative manipulation due to small pupil and loss of corneal endothelium. Thorough preoperative workup regarding zonular integrity, pupillar dilatation, and intraocular pressure helps to decrease intra and postoperative complication in these patients. Surgical planning includes choice of viscoelastic pupil expansion devices, capsular tension rings, choice of surgery, and having an inventory of iris claw or scleral fixating lens helps to increase the safety margin while operating on these complicated cases. Conclusion: patients with pseudoexfoliation undergoing cataract surgery have high incidence of intraoperative and postoperative complication. Although cataract with pseudoexfoliation is a challenging scenario to operate upon, a proper preoperative assessment and case-based management plan is required, as the magnitude of problems may vary from patient to patient. It is possible to achieve good results in most patients by taking adequate preoperative precautions and readiness to handle intraoperative complications. Affordable and easy access to surgical accessories like iris cloths, clear fixating IOLs, capsular tension rings, iris retractors and hook have helped us to manage intraoperative complications appropriately with acceptable visual outcomes. Thank you.